This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is the role of genetics in breast cancer and is sponsored by King Quality Construction. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We'll answer as many questions as we can within the time allotted once the presentation concludes, and your questions will remain anonymous. Today's presenter is Dr. Jerry George. Dr. George received his Bachelor of Science through an accelerated program at New York Institute of Technology, where he also received his doctorate of osteopathic medicine. He then completed his categorical internal medicine internship and residency at the New York Medical College at Westchester Medical Center and his hematology and medical oncology fellowship at Lenox Hill Hospital. Among his many professional honors and scholarly activity, Dr. George has had multiple medical publications published throughout his career, and he is currently an adjunct assistant clinical professor at Mount Sinai. Dr. George joined the team at New York Cancer and Blood Specialists in the summer of 2013 and has special interests in cases focused on lymphomas, multiple myeloma, and lung cancers. Dr. George, I'm going to stop my screen and you can go ahead and get us started today. How are you?
I'm good. How are you?
Good.
Share my screen. Is this Sharon?
Yep, we could see it.
Perfect. So thank you for the introduction. My name is Jerry George, and I'm a medical oncologist with New York Cancer and Blood. So today we will be talking about breast cancer and breast cancer genetics specifically. So it's a pretty big topic, but globally, breast cancer is the most frequently diagnosed cancer and a leading cause of death in women. In the United States, it's the most common diagnosed cancer and the second most common cause of death. When a doctor is dealing with breast cancer, you usually have a team approach to it, where you have a medical oncologist and a radiation oncologist, as well as breast surgeons, all involved in the care of a patient, as well as other individuals like nursing, social work, nutrition. Everyone is there basically to help patients in their care and their battle with cancer. So the average woman's risk of developing breast cancer is about 15%, or I like to say it's usually 1 in 8 women, which is somewhat high. That increased risk becomes higher and higher as a woman gets older. There are other things that may increase a woman's risk of developing breast cancer, and that's where genetics comes into play, where mutations such as BRCA mutations and other mutations may increase a woman's risk of developing breast cancer. Other malignancies, a personal history of ovarian cancer or peritoneal cancer, breast cancer, may also increase a woman's risk of developing recurrent breast cancer or other cancers. And also receiving radiation to the chest can also increase a woman's risk of developing breast cancer. So in the United States, breast cancer accounts for about 260,000 cases of cancer per year. And that's responsible, and it's responsible for about 40,000 deaths in a year. The actual incidence of breast cancer has been decreasing from 1999 to 2007, and that's probably related to a higher incidence or prevalence of screening at younger ages. Also, the mortality associated with breast cancer has been decreasing since the 1970s. Again, likely related to screening, improvement in screening, as well as the the increased treatment modalities available. The main thing is that screening for breast cancers earlier in life saves lives, basically. So about 5 to 10% of breast cancers are thought to be hereditary, and that's caused by an abnormal gene passed from parent to child. So genes are short segments of DNA found in chromosomes, and DNA contains the structures for building proteins. And proteins in a person's body control structures and function of cells and help make up the body. So genes are instructions for cell growth and function, and changes in DNAs are errors that provide for the wrong set of instructions, leading to a faulty growth of cells. There are two types of DNA changes that are those that are inherited and those that occur just through living. Inherited DNA changes are passed down from the parent to the child, and those are called germline altercations or mutations. Changes in the DNA that occur over the course of a life are called somatic mutations. And these can occur because of natural aging processes, as well as exposure to certain chemicals. Some DNA changes are thought to be harmless, but other mutations, like BRCA mutations, can cause significant harm. So this is just a little graphic that shows somatic mutations versus germline mutations. So like I said before, somatic mutations are mutations that occur just through normal living. They are typically not inherited, so you can't pass them along, but germline mutations are mutations that are inherited and something that usually a parent can pass along to a child. So, like I said before, most ovarian cancer, breast cancers and ovarian cancers are sporadic, but about 6% are thought to be are inherited or germline mutations. And 20% of ovarian cancers are thought to be related to a pathologic variant as well. So the most common ones that we always think about and the ones that are associated with higher risk of mutations or pathologic mutations are BRCA1 and BRCA2. And there's a strong incidence associated with breast cancer and ovarian cancer associated with those mutations. There are other mutations that are less known, but also significantly associated with hereditary risk of breast cancer. And those include TP53 mutations, PALB2 mutations, P10 mutations, ATM mutations. There's a wide variety of mutations that can be associated with cancers, especially breast cancer. So while unaffected individuals often present with concerns about their hereditary risk, cancer risk, whenever it's possible, it's ideal to initiate genetic testing in a family member who is most likely to test positive for a pathologic variant, which is usually a woman affected by early breast cancer or ovarian cancer at any age, because that'll usually lead to a higher yield of finding an abnormal mutation. The optimal person to test within a family could include individuals with other diagnoses, such as pancreatic cancer, metastatic breast cancer, or metastatic prostate cancer, even if they don't have a history of other family history for cancer. So how do we determine who to test? Basically, that's based on guidelines that come about from the National Comprehensive Cancer Network, the American College of Medical Genetics and Genomics, and the National Society of Genetic Counselors. And they go through a detailed criteria of who should be tested and who should not be tested. So this is coming from the National Comprehensive Cancer Network. And this is a basic guideline of who should be tested and who should not be tested. So basically, anyone with a family history for breast cancer, a personal history with breast cancer that was diagnosed below the age of 45, or anyone between the age of 46 to 50 with multiple primary breast cancers, especially in the family, or family history for other malignancies, including breast cancer, ovarian cancer, pancreatic cancer, prostate cancer. Or anyone over the age of 50 with multiple family members with malignancy. And then you can also test individuals where there may be a drug that with a personal history for cancer, and there may be a drug that might help in aiding their treatment. So again, these are basically criteria on who should be tested. Again, a woman that has breast cancer, but it's diagnosed at a very young age, usually less than the age of 45, or history of breast cancer between the age of 46 to 50, with multiple primary breast cancers, or more than one family member that has a history of breast, ovarian, pancreatic cancer, or prostate cancer. And then there are other criteria, like things that you look for: someone that has a history of triple negative breast cancer, metastatic cancers, as well as pancreatic cancer or prostate cancer can be tested. And then there's certain ethnicities that have a higher risk associated with BRCA mutations, and that includes people of Ashkenazi Jewish ancestry. So again, this is a little cartoon that says that who should be tested: more than one relative with the same type of cancer, family members with multiple types of cancers. So in the past, testing was very, it was a little more, it was a little harder to fall into criteria to be tested, but nowadays we're expanding the criteria for testing to a lot more individuals. So what do you base testing on? So there are a lot of mathematical models that have been developed to ascertain the risk of an individual's risk of harboring a pathologic variant, such as BRCA1 and BRCA2 mutations. So this includes a lot of these algorithms base the importance of testing on a lot of factors, including if someone has a personal history of cancer, such as breast cancer, how old they were diagnosed, how many family members they may have that have had a history of cancer, especially breast cancer. So a couple of these algorithms include the BRCA Pro algorithm, the CAN-RISC algorithm, the CLOS algorithm. One of the more commonly used algorithms is the breast cancer risk assessment tool. So these are, if you're interested, these are some websites that you can actually find that can go into risk assessment a little bit. That includes the CAN-RISC that we were talking about before, as well as the National Cancer Institute has a risk model available. So testing is obviously very important, but it's also quite important to seek genetic counseling. So genetic counseling goes into a lot of different important details behind testing for these genetic alterations. And so pregenetic counseling is quite important to the genetic counseling and the testing itself. So the whole purpose of pretest counseling is to provide an individual with a genetic risk assessment based on their personal and family history, and also to discuss the options and implications of genetic testing. So what would pre-genetic counseling include? So that includes assessment for medical history, and there's also something that we perform something called a pedigree that looks at family history. So an important component of pre-test counseling is detailed review of the patient's past medical history and family history, which should include information on materials and maternal information on maternal and paternal relatives, preferably covering at least 3 generations. This process is key not only to determining which individuals should undergo genetic counseling, but also is instrumental in ordering the right test and counseling the patient about the rationale for testing, the likelihood of obtaining a positive test. So also pre-genetic counseling goes through mathematic models, which may be used for provided the patient with an estimated cancer risk, the likelihood of a positive test for gene mutations. So it is also pre-genetic counseling also talks about genetic testing recommendations. So there's more than one type of genetic test available, so they can go through those basically which best test is suited for that patient, which will provide the highest yield of finding out if a person has a genetic alteration or not. So that would be able to look to see if someone may benefit from next generation sequencing, whole gene sequencing, or single mutation testing. And then they would also talk about the implications of genetic counseling. So what would be, how would the genetic test impact your life? So would that include testing of family members? Would that include testing, would the testing warrant the need for other procedures? That could be significantly stressful and should be also discussed. So also pre-genetic counseling goes into discussion of financial matters. In the United States, most insurance companies cover 90% or more of the cost of commercial breast cancer susceptibility testing or multigene panel testing in the appropriate candidate. Several commercial-based labs cap patients' out-of-pocket costs. And if testing is covered by insurance, a letter of medical necessity may be required to document the potential impact of a positive test result on surveillance or surgical recommendation for a patient. For patients without insurance, financial assistance programs exist through many labs. In addition, some companies offer self-pay options for multi-gene testing for $250 or less. So when I started doing genetic testing several years ago, the expense, there was a great expense associated with this testing. It could have been several thousands and thousands of dollars, which could be very cost prohibitive, obviously, for people when it may not be covered by insurance. But with the use of new technology and the availability of next generation sequencing, the cost of genetic testing has really come down significantly, which allows it to be available to a lot more people. So then most people don't think about this, but pre-genetic counseling should also go through discussion of legal protection against genetic discrimination. So one of the primary sources of concerns about potential harm patients undergoing genetic counseling stems from their fear of genetic discrimination, which can be a common reason for declining genetic testing. But fortunately, in the United States, federal and state laws provide many protections against discrimination, genetic discrimination. So that shouldn't really be, nowadays, the fear for genetic discrimination shouldn't really prohibits you from testing. So if you need testing, you really should get genetic testing. So earlier I was talking about when you do genetic counseling, we perform something called a pedigree. Pedigree is basically looking at your family history. So this may be the infected, the person that's coming for testing. We just don't want to know about that person coming in, but we also want to know about all their family history. So are their parents, do they have a family history for malignancy, not only breast cancer, but other types of cancer? And who in their family is affected? Is it only on their maternal side, or is it also on their paternal side? If they have brothers or sisters affected with cancer, and what types of cancer. And that really does tell us what we might expect from the genetic testing, and how positive, what their likelihood of testing positive may or may not be. So for most patients meeting the criteria for testing, next generation multi-gene panel testing is offered, including for those previously tested without a next generation multi-gene panel. So basically, next generation multi-gene paneling is the way we test most patients now for any type of genetic alterations or pathologic genetic mutation. It's usually a very fast result that provides a very accurate and cost-effective way of determining if someone has a genetic mutation or not. And so, although pathologic variants in breast cancer genes such as BRCA1 and BRCA2 are most commonly implicated in women with classic signs of hereditary breast and ovarian cancers, approximately 4 to 7% have a pathologic variant in another gene with probable breast and ovarian cancer associations. And the most common genes that we usually may see in moderate risk genes include CHEK2 mutations, BRCA mutations, and ATM mutations. BRCA2 mutations, PALB2 mutations, as well as ATM mutations. So how do we test individuals? So there are a lot of ways to test someone, including use of blood testing, saliva testing, as well as the buccal mucosa. You can do swab testing as well. That we may be able to find, that we may be able to send samples for the genetic testing. So testing for abnormal breast cancer genes are sent to a commercial lab typically, or a research testing facility. During the test, the genes are separated from the rest of the DNA and then are scanned for abnormalities. Multi-gene testing, also called panel tests, look at a set of genes for mutations all at once. And so this multi-gene testing can test for as little as 2 mutations, 5 or 6 mutations, 20 or 30 mutations, or nowadays even like 80, 90 mutations. And this is what they call as next generation gene sequencing because of the newest technology that are used to sequence the genes. And there are a lot of companies that are available, or labs that are available to perform testing, such as BRCA1 or 2 mutations. That includes like Myriad Genetics, Ambry Genetics, and GeneDx. So, like I said, we usually do next generation multi-gene sequencing to look for genetic mutations. There are other ways that we can test people, but they're typically not recommended. That includes sequencing of the whole DNA. Most data suggest that this is unlikely to yield an actionable result, and it's not that much better than than the multi-gene testing that we typically do. And there's also a possibility of false positives that can be seen in this as well. Then there were companies like 23andMe that got approval for BRCA1 and 2 testing. This isn't typically recommended because really there isn't any genetic counseling that's provided with this. So you get a result and really don't know what to do with that result. So again, coming for genetic testing is probably in a person's best interest. And then we usually, even if someone has an abnormality in this, we usually do repeat testing either way to kind of confirm and to assess for other mutations. So what do you do with these results? So there's a possibility of a negative result. So that's a completely negative genetic testing result. And so with a woman with true negative BRCA1 or 2 mutation testing or other genetic mutations, they're typically counseled and told that their risk of breast and ovarian cancers is pretty much the same as the average public or maybe slightly higher. The result does not rule out the possibility that one may still have a hereditary risk of cancer. It is possible that the genetic testing did not include all known genes associated with cancer, nor all variants known to be present in the genes can be tested. And some genes just haven't been discovered yet. So although the testing may be negative, there's still always a possibility that a gene hasn't been discovered and a person's risk might be slightly higher in that case. So then we come upon something called variances or variances of uncertain significance. These are when gene alterations are identified, but its clinical significance is unclear. So it's called a variance of uncertain significance. In this instance, it is unclear if the variant is an undefined pathologic variant, so it may be a problem, or it could be a benign genetic mutation, so not associated with a higher risk of malignancy. Or it may be associated with an intermediate or medium risk of developing a malignancy. So those individuals should be managed based on their personal or family history and should not be counseled as though the variant is pathologic, or they shouldn't be told that the risk is higher of malignancy associated variances because we just don't know. So also, given the high rates of variances obtained from multigene testing, patients must be informed that such findings are expected and over time that these variances may be reclassified. So in the future, as more and more data is obtained about these variances, they might be reclassified, as in they might be associated with a higher risk of malignancy, or they may not be associated with any risk of malignancy at all. And so then there's a chance that someone might get results back, and that can be associated with a high risk. So women deemed to be at high lifetime risk of breast cancer, identified at least 20%, should undergo annual screening mammographies, annual breast MRIs, and clinical breast examinations every 6 to 12 months, usually beginning 10 years prior to the age at diagnosis of the youngest affected family member, but not prior to the age of 30 for mammography, and not prior to the age of 25 for MRIs. And if you have a risk between 15 to 20%, you may also consider breast MRIs as well. So these are actually 2 sample reports that I found that someone may see associated with both the Ambry testing as well as the Myriad testing. So it's actually quite clear cut, where you can actually see one of the first things that they write is for, let's say, the Myriad testing, it says positive for a deleterious mutation. So it's written right there. And the same thing's true for the Ambry testing, where it's clearly written, there's a variance of uncertain significance detected. This report's not by itself. There's also number of pages associated with that actually go into that mutation and what to expect from it, what may need to be done based on that mutation. So, managing the risk of cancer. If one tests positive for a BRCA1 or 2 pathologic variant, there's several ways to screen for cancer and to reduce the risk of developing cancer. One is, like I mentioned before, having more frequent screening for breast and ovarian cancer. There's also possibilities of having surgery to reduce the risk of breast and ovarian cancer. And someone with a high-risk genetic mutation, like a BRCA mutation, can also take medications to reduce the risk of breast and ovarian cancer. So like I was mentioning before, with high-risk genetic mutations like BRCA mutations, you should have an annual breast exam every 6 to 12 months, beginning at the age of 25. Also, mammographies and breast sonograms, breast ultrasounds can be performed yearly at the age of 30, or if a family member is diagnosed, it's usually 10 years before then. Then also doing breast MRIs would be also useful, at least once yearly. What I typically do in a lot of my patients is do alternating every 6 months, either doing a mammography or breast MRI every 6 months, just to capture as much as possible. Then if you have a high-risk mutation, you should have the sense of breast awareness where you can do self-examinations on a regular basis. So I mentioned before about having surgeries to reduce the risk of malignancies. And so that includes surgeries like a mastectomy. Basically, that can, it's called a prophylactic mastectomy, a bilateral mastectomy, and people that have high-risk mutations. And this can reduce the risk of developing breast cancer by about 90%. So that's a significant risk reduction associated with BRCA mutations. And there are procedures called prophylactic bilateral salpingo-oophorectomies, and that can reduce the risk of developing ovarian cancer by about 80 to 90%. And it can also reduce the risk of developing breast cancer by 50%. And then there are also certain medications that can be provided by your physician to reduce the risk of malignancy, such as breast cancers, such as drugs like tamoxifen or aromatase inhibitors that can significantly reduce the risk of malignancy. So BRCA mutations are associated with significant risk of malignancy, like we were talking about before. In general, someone with a BRCA mutation has about a 70–90% risk of developing breast cancer. It's associated with a 40 to 60% risk of developing ovarian cancer. Men that have a BRCA mutation or have a higher risk of developing prostate cancer and even male breast cancer. There's also associations with other cancers such as pancreatic cancer, colon cancers, and melanomas that can be evaluated. So there are lots and lots and lots of different mutations, more than just BRCA mutations, that are associated with moderate and high risk developing of breast cancer. So like there are mutations called ATM mutations that have about a 15 to 40% risk of developing breast cancer, as well as CHEK2 mutations that are associated with about a 15 to 40% risk of developing breast cancers, as well as PALB mutations associated with 40 to 60% risk of developing breast cancer. And a lot of times this risk can be somewhat mitigated by the use of screening exams like mammographies and breast MRIs, like I mentioned before. Okay, so There are a lot of risks associated with developing cancer. So breast cancer specifically, obviously more associated with the female gender. Genetics, like we mentioned before, there's also associations with early menarche, obviously family history, late menopause, exposure to radiation. They all can increase the risk of developing breast cancer. So what can someone do to reduce that risk? So obviously we can't get rid of our genes, but if we maintain a healthy weight, regularly exercise, limiting alcohol, not smoking, eating foods that are not processed and nutrient dense, these are all things that that can help a woman reduce the risk of developing breast cancer. So these are things that are actually in our control, and some of these things are kind of hard to do. I know it's really hard to exercise on a regular basis, but these things can really help reduce the risk of developing cancer. So I think those are things that are in our control and really will help us. So very, very important if we can do that. So these are certain organizations that you can find that can offer more information that are very reliable, like the National Cancer Institute, the American Society of Clinical Oncology, and the Facing Our Risk for Cancer Empowerment, Cancer Empowered. So these are all websites and sites that can give you some more information if you're interested in breast cancer as well as genetics associated with breast cancer. So does anyone have any questions?
Awesome. Thank you so much, Dr. George. That presentation was incredibly informational. If anybody does have any questions, please feel free to enter them in the Q&A spot at the bottom of your screen. We'll take as many as we can, and we'll be able to send out a recording to this presentation in case, there were some parts that you wanted to read a little bit more about. You'll be able to rewatch everything. Dr. George, why don't you walk everybody through what it would be like to get this done? So they call and make an appointment with your office, or, how does that kind of work?
So basically, a lot of my patients that I go through breast cancer or breast cancer genetics with come from Mather, and they'll a lot of times be assessed at the Mather Fortune Breast Center, and the risk assessment will be formed there, and they'll be sent to my direction, or they'll have someone that has a family history for it, and they're really obviously concerned about their risk of developing cancer, just like a family member. And they'll come in, and we'll kind of go through everything. We'll talk about we'll talk about their risk associated with having a genetic mutation. We'll go through the various mutations that are possible, like high risk, moderate risk, or variances that are possibly associated with malignancy or breast cancer, and how this may impact their life. So it's not just getting a blood test or genetic testing done. There's a lot of implications to it. Having surgery like a prophylactic mastectomy or a prophylactic oophorectomy, those are really intense subjects that can be very scary to an individual. So we'll talk about that, and we'll kind of review the implications of that and what may be done. And we'll also talk about the importance of high-risk screening with breast MRIs and mammographies and breast sonograms to see what we can do to mitigate that risk. And also go through financials as well as testing of family members if they have it, if they have an abnormality. We'll go through as much as possible and review everything.
Fantastic. You spoke a little bit about a healthy diet to reduce the risk of breast cancer. Can you talk a little bit about that? You know, maybe kinds of foods you should stay away from, things that you should really be filling your diet with?
So that's, healthy diets, it's a great thing and can be sometimes hard to do. For me, myself, I know that's kind of challenging to stay away from the bad things that I probably shouldn't eat. And basically, it's reducing a lot of the fatty intake, high saturated fats that we normally have in our diet. A lot of the processed foods should kind of be eliminated. So like things like going out to eat, it's fun, but like probably limiting the amount of fast food that we eat is very important. I usually tell my patients just go by a well-balanced diet, like a lot of fruits and vegetables, a lot of fiber, limiting the fat, a lot of lean meats, so like chicken, fish, they're great things. Good fats are good things, but bad fat is bad. So like, bacon's great, but probably that fat associated with bacon is probably not so great for us, especially it is associated with a higher risk of cancer when we eat a lot of these processed fatty foods, especially breast cancer.
Okay, perfect. I see a couple of questions coming through here. You might be able to read them yourself in case they get a little wordy if you click the Q&A at the top of your screen, I think.
Okay.
So my mom had breast cancer twice, 2 different primaries, and ovarian cancer in her 50s. I was diagnosed with breast cancer at 46 years old. She is BRCA gene negative. I tested negative for the basic multi-panel gene test, but should I consider getting tested for an expanded gene sequencing test?
So that's something that we would usually discuss in the office, but I would really think about it. I would consider it. Again, like a lot of these mutations are not known, and sometimes multi-gene testing won't pick it up, even if we do an expanded panel. Like I said, I was mentioning before in the slides, there are mutations that we just haven't discovered yet. So it might be something that's not discovered yet. And, there's a significant, sounds like for this person, there is a significant, family history and personal history of malignancy. And so an expanded panel may be worthwhile. But again, there are certain mutations we just haven't discovered.
Okay. I was diagnosed with breast cancer almost 10 years ago at 58 years old. My daughter has suffered with severe endometriosis at age 40 and had a total hysterectomy. I know things are not too clear in the treatment of endometriosis, but would any genetic testing be something to investigate in this case?
So I think you're right, where it's kind of unclear about the role of genetic testing. The other things that would be important are like other family history for cancer. The patient herself, has she been tested for breast cancer? Those are kind of important things. Usually we try to test the person that has a history of cancer. And then if they have a mutation, then we can suggest testing of family members.
Okay, great. Looks like that's all the questions we have right now. Thank you everybody for joining us today. Thank you, Dr. George, for taking the time out of your crazy schedule to be able to speak with us today.
No problem.
Everybody, please enjoy the rest of your day. You'll be receiving a recording to the webinar. Thank you.
Thank you. Have a great day, everyone.